There we go. That's the equivalent of a gong, the official bell that starts the meeting. So this morning we have the pleasure of the Porter Lecture, and we'll have the proper introductions for that and for our speaker. But the focus today actually is on COVID, and we're going to start with a briefing by Brian Cummings. Brian?
Hello, everyone. Can you hear me? Just going to share quick slides. All right, I'm just going to give a quick brief COVID update here. The pandemic remains, as you can just see from the New York Times infographic, high level of cases pretty much throughout the US, going down a little bit in the Midwest, but now peaking again in the West and the Northeast and the South, and likely to exceed the previous peaks we've had. Just zooming into the Northeast, Rhode Island was the third by capita in the world last week. It's come down a little bit this week. And so it's been a big hot spot, and you know about the last couple of weeks. We've exceeded now, on average, more than 200,000 positive cases a day, and hospitalizations set new records every day. What's going on locally at MGB? So this is just a few days old, but you can see the distribution of COVID positive admission cases throughout the system. Mass General Brigham has been busy. MGH has been the largest bearer of COVID patients. This says 112. Actually, today we're 132. The Brigham says 68. I believe it's 81 today. And the Faulkner, I believe, is 25. If you look on the right side, that's our trend over the last week. You can see that we've been going up in our inpatient cases. Last week, we were about 90. It says 120. Like I said, I think formally we're 125 admissions today, and another 10 are in the ED right now. There are 36 cases today in the ICUs, including 2 in the pediatric ICU. Our inpatient census for COVID pediatrics has been around 4 to 6 patients a day. It says here 4. Actually, this morning we have 5 COVID positive patients. Like I said, 2 in the pediatric ICU. So we remain busy. And on the ambulatory side, it's no different. We continue to have a surge in positive pediatric patients. This is all the children tested in the MGB system. We're averaging about 1,300 tests a week right now. Last week we had 12.4% were positive. Obviously, this is the surge post-Thanksgiving, and you know there's been lots and lots of cases related to the gatherings there. This week it's a little bit lower at 9% positive, but still 3 times what it was just 3 weeks ago. There's still about 7% of the tests aren't back yet, so that will probably go up a little bit. You can see in the zip codes kind of all around our area, more on the North Shore than anywhere else. And by ages, you know, our teenagers continue to be more, have a higher positivity rate than our younger kids, but not that much more so. It's averaging 7% in our preschool ages, 10% in 6 to 11, and 10% in 12 to 18. What are we projecting? We're projecting it to continue to increase in the system, and our inpatient volume to only get worse. The black line is the projected census. In the middle is the median projection. The top dash line is the 75th percentile projection. When I showed this to you about 10 days ago, the median was flat and the 75th had been going up. So we're following more the 75th percentile. So we project to be over 200 inpatient cases by Christmas. The inpatient ICU census appears to be flat. That's more likely to stay that way if we don't go into surge ICUs. So it depends really what's going on in the rest of the state. You know, obviously, given this news, the state has already rolled back their opening plans. And then yesterday, different communities have announced more stricter measures to control the spread in Boston. I expect all those restrictions to become worse in the next week or two until inpatient capacity is restored throughout the state. What about some good news? I'll just go on to the vaccination efforts. All of you have seen the pictures of people getting vaccinated in the state. The system has released their plan for administration of the vaccine. Testing is going on today. for the system and how to register for your vaccine. There are waves, and they're asking you to go by the honor system when you fill out, are you eligible right now, or can you wait a few weeks? The whole employee vaccination program is anticipated to take about 2 months to get all the employees in the system. There are details that have been sent in the broadcast email, and it's also on this slide you'll get later. And again, this can all be scheduled through your COVID pass that you would test for your symptoms every day. It'll determine your eligibility, and then you can schedule your vaccine. This should be live tomorrow if everything goes well with the testing today. And just a reminder, if it's going to be here, the vaccination clinic is in the Russell Museum where the flu clinic was. If you don't have access to the COVID pass, you can schedule your vaccine at the Coffee Central. There will be monitoring for your symptoms post your vaccine, which will be a red cap survey. There'll be instructions on what type of symptoms you have to report to occupational health. And there are detailed facts now on your monitoring, on pregnancy, on allergy, and on lactation. So all those are in the resources available to you. And then my last word is just about flu shots. Again, the Commonwealth needs all our children vaccinated to stay in school. And our efforts to do flu vaccines beyond primary care clinics have been very successful so far this year. We've gotten up to 68% of our inpatients now in the last 3 months, and 60% of our ambulatory specialty visits have documented flu shots, which is almost double what we did last year. So keep up the good work and try to finish on this final 2 weeks, getting all our kids vaccinated for the flu. I'm going to end there and let Dr. Pasternak introduce our speaker.
I'd like to begin by saying a word about Dr. Phil Porter. I met Dr. Porter through our weekly pediatric infectious disease conferences. Dr. Medeiros on the right had invited Dr. Porter to join us each week, and Phil attended our weekly infectious disease meetings for many years. At that time, he was chief of pediatrics at Cambridge Hospital and brought a wonderful amalgam of primary care and infectious disease subspecialty knowledge to the conference. He offered us a sense of history and a sense of common sense, which was unique. His presence at the conference was really a gift to all of us. Phil was one of the gentlest and kindest physicians I've ever known. Everything I'm about to say I've learned from others because he never spoke about himself. He graduated from Princeton University and received his medical training at the University of Pennsylvania. He went on to train in infectious disease with Max Finland at Boston City Hospital and spent much of the rest of his professional life at Cambridge Hospital. In the 1980s, he took over the challenge that Julius Richmond offered to establish a school-based healthcare program for high school students, and he went on to set up dozens of these programs throughout the country and traveled widely in support of them. In 1987, he received the American School Health Association's William Howe Award for Outstanding Contributions and Distinguished Service in School Health. A fund in his memory was established by his friends and colleagues and supports several educational efforts in our department, including this lectureship. It gives me great pleasure to introduce Dr. Adrianne Randolph, who will be deliver this morning's lecture. She's a professor of anesthesia and pediatrics at Harvard Medical School and is based at Boston Children's Hospital. After graduating medical school at Stanford, she trained in pediatric residency and critical care at UCSF, went on to get a master's in bioinformatics at the University of Utah, and then completed a research fellowship in pulmonary physiology at Toronto's Sick Children's Hospital. She's been on the staff at Boston Children's Hospital for the last 23 years. She's the founder and the first chair of the Pediatric Acute Lung Injury and Sepsis Investigators Network, which is a mouthful. It's a clinical research consortium of over 80 pediatric ICUs throughout North America that's worked together for over 20 years. She went on to found a subdivision that focuses on influenza and emerging pathogens, and is now leading a CDC-funded study of severe complications of COVID-19 in children and adolescents across 70 pediatric hospitals across the country, called Overcoming COVID-19. She's been funded by the CDC and by the NIH, and has over 200 publications, beginning with a Nature publication prior to starting medical school. So Dr. Randolph, welcome this morning. We look forward to your talk.
Thank you. And thank you for the invitation. That was it's a very timely talk with the surge again with COVID. I'm going to be focusing my talk on multisystem inflammatory syndrome in children and adolescents related to SARS-CoV-2. I have no disclosures. My objectives are to first talk about its emergence and then how it's distinguished from Kawasaki disease, toxic shock, and severe acute COVID-19, and then to focus more on the current treatments, health outcomes, and its immunobiology. So in April, late April, there was alerts in both Italy and the UK about a syndrome of that was emerging in children with Kawasaki-like features and toxic shock-like features of these previously healthy children, often had abdominal symptoms, and then fever, and would present with very severe illness. It then was seen in New York, mostly around New York City. And very soon after, May 15th, a worldwide alert went out about this new syndrome called MIS-C. And they had definitions from the Center for Disease Control, the World Health Organization, as well as an alert from the European CDC. This is the case definition from sorry, I'm just trying to get this to go away on the top, but this is the definition from the CDC. So these are patients under 21 years of age, fever, inflammation, multisystem, at least 2 organ involvement, no alternative plausible diagnosis, and some type of association with SARS-CoV-2. Now, it could be antibodies, it could be an antigen test or a PCR test, or just some type of presumed exposure within the 4 weeks prior to the onset of symptoms. And a lot of the patients that first emerged, because antibody testing wasn't available, just had presumed exposure. And the fever didn't have to be for very long. Some individuals could meet partial or full criteria for Kawasaki, and it was said to consider MIS-C in any pediatric death with evidence of SARS-CoV-2 infection. Now, these are very broad criteria, and a lot of patients who present to the hospital prior to SARS-CoV-2 could meet these criteria, and that's a theme that I'm going to talk about later. So how is MIS-C different than acute COVID-19? First, in the first wave of cases, and there was some publications in JAMA Peds and New England Journal, the only pediatric data on severe cases showed that it was very, very rare to have critically ill children intubated for hypoxic failure. Most of them had a lot of comorbid conditions. However, the MIS-C cases with these first 2 reports in the Lancet were previously healthy, and as I mentioned, had KD signs, shock, and it appeared about 2 to 4 weeks after peak COVID activity in the community. So the Overcoming COVID-19 project, the goals of it are to understand severe disease complication in children and young adults from COVID-19, including multisystem inflammatory syndrome in children, temporally related to SARS-CoV-2. And we're doing public health surveillance of 2,000, and right now in our registry, we have 1,820 patients. So we're almost filling up the registry of children with severe and adolescents with severe complications. We also have this immunobiology study where we get consent and collect blood and other samples. And we have a website, overcomecovid.org. So we have 75 sites in the surveillance registry, 45 sites in the prospective cohort study. We initiated this study very quickly because we were set up from the last pandemic with a protocol IRB approval at 30 sites to be able to collect data quickly. We also were able to set up the immunobiology study quickly because we already had 26 sites enrolling for an influenza vaccine effectiveness study. The surveillance registry aims were to understand risk factors and outcomes of COVID-19 and to understand and better define the complications in young individuals thought to be related to SARS-CoV-2, and also to real-time inform government decision makers. So we took the data from the sites, we captured the data with waiver of consent, and technically this is not considered research because we're tracking, as long as these requirements that are on this website are still in draft form, even though it's been since 2018. However, there's 3 criteria stating that something is public health surveillance, and you really don't even need IRB approval. That as long as it's focused on this pathogen, that a public health agency or authority or any type of outbreak states is an emergency and is focused specifically on that, it's considered public health surveillance and not research. So very quickly, we were able by May 25th to submit this article to New England Journal, capturing data from 26 states and multiple sites that we on multisystem inflammatory syndrome, and that's what so we had 186 cases, 26 states, and most of it was in the Northeast, a bit in Michigan. That's where the outbreak had been peaking and where the first cases of MIC were reported. One question that comes up is, sorry, I'm just trying to get rid of this from the top of my screen. Well, anyways, is how the timing relates to MISC and COVID-19 activity. And, you know, the one feature of MISC is that it was peaking 2 to 4 weeks after the peak of COVID-19 in pretty much all studies. There was a second report of just New York State. You added up the 2 studies that were in New England Journal, ours and the New York State. We had taken out some of the New York State reports. They showed the same relationship as did the studies in the UK, the patients in the UK that were reported. So a lot of the children who were reported, there was a disproportionate number of children who were Hispanic or Latino ethnicity or Black non-Hispanic compared to white non-Hispanic with MISC. There was in our report a much higher rate of male children, but that's just a little bit higher in later reports. But there's a very consistent reporting of the peak of the age group somewhere between 8 to 12 years old, 5 to 14 years old, which is a little bit odd that the greatest number of patients are sort of in this age group with a median age of 9 years. And so a question becomes, why are these patients overrepresented? Is it just exposure that these communities have higher exposure to SARS-CoV-2? So one of the things that we're doing is doing a case control study of risk factors for MISC, as well as a prospective study that we're planning to look in the history of these patients to try to figure out, kind of like in a RISE syndrome type approach, of what are the exposures in this population aside from SARS-CoV-2. So cases, as I mentioned, met these 5 criteria, and you know, these are very broad. So how can we improve this diagnostic criteria to increase the specificity without losing sensitivity? Which of these features of MISC patients really distinguish them from acute severe COVID-19 and other presentations? And that's a big question. Well, cardiovascular involvement, of course, is one of the primary features. In fact, cardiovascular or Kawasaki disease criteria highlight the WHO definition, which is a little bit more specific than the CDC definition. But 90% of these patients had echocardiograms from our prior report, and about 40% had impaired ejection fraction. And 8% had coronary artery aneurysms, with a bit more, closer to 12% if you looked at dilations, which is a Z-score between 2 to 2.5, and almost half needed vasopressor support. So the cardiovascular system was very important. And, the question here is, what's the long-term effect on the cardiovascular system? So one thing that is going on is Jane Newberger and her colleagues are doing this study that's now funded by Pediatric Heart Network, following up all these children with cardiac involvement and without cardiac involvement who have Kawasaki disease-like features, to look at the longer-term outcomes of the cardiovascular system. And we've now just completed a large study of 516 patients looking at these coronary artery aneurysms, of which very few were between moderate size, that's between 5 and 10 as Z-score, and we didn't see any really large ones in our cohort. So most of these were on the small size, and a lot of them resolved fairly quickly of these coronary artery aneurysms, and other people have reported that as well, whereas the fear in Kawasaki disease is that these aneurysms will be larger and long-lasting. So, and these are, a big question is, how much of this cardiovascular involvement is just from acute severe COVID-19? Because we see this in adult patients. There is, a lot of cardiovascular involvement now noted more and more in adults with acute COVID-19. This is just one of the studies. There's multiple organs involved, however, in COVID-19, and including gastrointestinal, hematologic, respiratory is very common in MISC and COVID-19, and that's something that people don't necessarily realize. They think that acute COVID-19 is mostly respiratory. MISC is really free of respiratory symptoms, although some patients don't have respiratory symptoms. The majority do have respiratory symptoms and signs and need respiratory support. And then what are the other long-term complications of patients who get this diagnosis? Some of them also have other things: ADEM, acute demyelinating encephalomyelitis, Guillain-Barré, severe bowel inflammation, coagulopathy. We've been partnering with other groups to follow up some of these patient populations. Inflammation is one of the hallmarks of MISC, and the inflammation is very profound. Lymphocytopenia is almost universal and in these patients, and neutrophilia, elevated D-dimers. CRPs are really, although the cutoff here is greater than or equal to 3, in most of the patients it's much, much higher than that. But which of these markers are really the features of this syndrome and should be more specific for diagnosing? Should some of these cardiac biomarkers that show muscular involvement of the heart part of the definition? That's unclear. Treatment is very commonly, patients are given IVIG, and as the pandemic went on and MISC cases continued, this number that was given IVIG has risen, and about 20% or so to get a second dose of IVIG still, and about half of the patients get steroids. And then there's some biologic agents that are given as well to these highly inflamed patients. A lot of them get anticoagulation because of the coagulopathy that's associated with it. Still, most of the patients go to the ICU, and not as many get mechanical ventilation, but a lot of them have vasoactive support. Death in this population is consistently around 2% or less. So death is rare in MISC in our ongoing study and state reporting. So it's really unclear what treatments are effective for which patients and for which outcomes, because it's a heterogeneous group of patients. And the IVIG is really based on this Kawasaki disease data that was published a long time ago, but is still the standard of care for Kawasaki disease, which, these are the features of Kawasaki disease that are that for part of the definition of the criteria for the syndrome. And if you have 4 out of 5 of these, or 2 to 3 of these plus labs, you have complete or incomplete Kawasaki disease. And then if you have aneurysms as well with some of these features, that's also part of the diagnosis. So of all these patients with MIS-C, and this has been fairly consistent even now with a larger cohort, only about 40% meet complete KD criteria or incomplete KD criteria. And then about 60% may have some other features, although they may have a few criteria, they don't really add up to all of the criteria. And those patients who don't have the Kawasaki, don't meet criteria for Kawasaki disease, still have risk for aneurysms. So, you know, the question is, we're treating these patients a lot like KD, but should we really be doing that? You know, this is sort of the KD algorithm for treatment of KD. And, you know, before this even started, there was a nationwide shortage of, I think worldwide shortage of IVIG. And so we're using IVIG, a lot of it. Now there is a MISA, Multisystem Inflammatory Syndrome in Adults definition and criteria. These are big patients. Their Kawasaki disease is usually under 5 years of age, and a lot smaller amounts being used. And so are we going to exhaust the supply? So how do we even look at what is the criteria? How do we even look at what works and doesn't work? Well, MIS-C is relatively rare. And, you know, although you can, if you track it, come up with 1,000 cases, it's all over the United States, with any one center not having a lot of cases. And randomized trials are somewhat inflexible, whereas MIS-C, we're still having provisional diagnoses in who do we target. Looking at comparative effectiveness, it's still very hard because of all the variability in what people are giving these patients when. So the consensus treatment plan approach, which is what the CARA network, this Arthritis and Rheumatology Research Alliance that we're partnering with, is one way to do this, where they develop standardized regimens close to what's being used in the community, and then clinicians choose amongst the regimen so that it's a little bit more consistent of a protocol, and then they collect data to assess compliance and compare outcomes. And that's one method of trying to look at what works and doesn't work. So in Kawasaki disease, the number of criteria the patient has is associated with the risk of having an aneurysm. That's not necessarily, as I showed you, what's seen in MIS-C. And then Kawasaki disease can be diagnosed even if in patients with fever and less than 4 criteria, but is that what we want with MIS-C? Just because somebody has an aneurysm, small aneurysm on echocardiogram, that all of a sudden C diagnosis. Kawasaki shock syndrome is very uncommon, where in MIS-C, most of these patients have shock. So the heart is involved in the majority of these patients. So overall, if you look at the two, Kawasaki disease versus MIS-C, you know, the differences are that MIS-C is older, has more GI symptoms, they're more inflamed, and they're more likely to present with cardiac involvement. So the second question is, what's the true incidence of MIS-C? And that's really unclear. But in New York State, where they were able to do more of a population-based capture early on, at the time they estimated 2 per 100,000 individuals less than 21 years of age, which makes it, again, very hard to do a randomized trial. We are trying to track MIS-C real time using these criteria of all those patients suspected early in hospital admission. About 7 of 10 actually get the final diagnosis. They either find something else or they don't actually meet MIS-C. And so, you know, taking a broad swath of looking at these CDC, using these CDC criteria, you're going to get a lot of patients with a lot of overlap of patients with acute COVID-19. And, with state mandated reporting, the numbers are growing, but how many of these have the diagnosis that you really want? Second, what is the true spectrum? One of the people who wrote the editorial, Mike Levine, for our New England Journal article, talked about it being the tip of the iceberg, because there's a lot of outpatients presenting now who may not have had severe enough illness to be hospitalized, but they had Kawasaki-like features, persistent fever, and should they also be seen by cardiology? We've actually at Boston Children's created a clinic in cardiology to evaluate those patients. There's other COVID-19 related complications in patients, including all of these other complications. About half of these patients get the diagnosis of MIS-C, half not MIS-C, unless they have cardiac involvement. Then it seems all of them get the MIS-C diagnosis. So, it can definitely, what multi-system involvement should give you the diagnosis of MIS-C. In this picture, where about a third of these patients have MIS-C, just looking at respiratory involvement, a lot of these less youngest patients, the infants, very rarely are getting sick from a respiratory standpoint. They're discharged very quickly, whereas there's not that much difference between these two groups, although the majority of this group has severe acute COVID and the majority of this group has MIS-C. So that's just another point that, there's a lot of crossover between these two populations. So how do we really distinguish which one of these patients, because just having a positive test, it could be a positive PCR, and about half of these patients are PCR positive with MIS-C, actually have COVID-19. It's clear that these MIS-C patients are more inflamed, but the GI and respiratory are not really very helpful because they're seen in both of these populations. And although they're given the label of MIS-C versus COVID-19, if they have cardiovascular or any mucocutaneous features, rash and a lot of these features and cardiovascular involvement are features of acute severe COVID-19 in adults. So how do we know that this is a post-infectious complication, which is what people are assuming is MIS-C? If you look at this is the World Health Organization criteria. If you look at these criteria, they had a little bit different than CDC, fever over 3 days versus any fever. So more like KD criteria, where it had to be prolonged fever, and 2 or more of the following, including rash, myocardial, or shock, could have been those 2. So they were a little bit more narrow in what features had to be present. And although as I've said, gastrointestinal presentation is just as common with acute severe COVID-19 in children. So we are also doing, because these clinical features aren't going to give us the answer, it's really important to do immunobiology studies. And we have 44 sites. We've now enrolled over 200 patients in this immunobiology study, looking at multiple questions, including genetic predisposition, cardiovascular complications, also looking at the virus itself and sequencing it, and looking at adaptive immunity and B cell and T cells. We get informed consent on all these patients, and we do post-discharge follow-up at multiple time points. And we try to get samples at 30 and 60 days when possible, which is really important. We have acute COVID-19 and MIS-C patients in here. We're doing a lot of different assays. We're doing antibody profiling with the FDA. And we're looking at a lot of, we're doing whole exome sequencing on all of these patients with MIS-C, and most of the patients with severe acute COVID complications to see if primary immune deficiencies may underlie this. It's really important to have the right control groups, though, for these studies, and that's what's been lacking in some of the published studies of MIS-C. This is one study that's from your own institution. Dr. Yonker, Dr. Alter, and Fasano published this in Journal of Pediatrics just fairly recently. It came out in paper, but it was published, I think, in August. Very important findings and early on, and shows the strength of what you guys are doing at MGH with your biobanking and everybody working together, was to be able to come up with these important findings. Just recently in Cell from Mount Sinai, they published this paper, noting that maybe autoantibodies, and they had some antigens that they probed and came up with some possible autoantibodies that might be underlying and driving this, and that has been another hypothesis. So, autoantibodies versus cross-reactive antibodies to SARS-CoV-2. These are some of the things people are investigating, but this is the issue. To really do this right, you need the control group, and you really need acute COVID-19 samples from age-matched healthy children, since most healthy children don't even get much symptoms of COVID-19. It's really hard to get these samples, but that's what you need to look at those who didn't get MIS-C. And then this is a study from JAMA early on that compared to KD. And in the UK, it's called PIMS-TS, Pediatric Inflammatory Multisystem Syndrome. TS was the first name. They had 58 patients, and they showed that they were much more inflamed than the KD patients, similarly inflamed as toxic shock. But they had some biomarkers that were really elevated compared to KD that weren't seen in KD. And then our own center, Jane Newberger, Mary Beth Sohn, and Hui Lee, also published early on this comparison of KD to MIS-C, showing that the amount of lymphopenia and neutrophilia is much higher in KD. Lymphopenia is much higher in MIS-C, and there are some differences there, and that compared to macrophage activation syndrome patients, these MIS-C patients are not as inflamed, although other centers have shown that. So it doesn't appear to be, there's some overlap, but there's not complete overlap cytokine-wise with macrophage activation syndrome. So longer-term follow-up of these patients is needed. We really need to look at quality-adjusted life years, the quality of life, because there is a lot more quality-adjusted life years left in these patients, and affecting the heart is very scary, and we don't know what is the effect on the cardiac muscle and long-term. And there's also been reports of effects on the arrhythmias and causing heart block, either temporary or longer term post-discharge. Severe neurologic effects are rare but can be devastating, and we really need to understand the longer term effects on neurocognitive function. So this is really what our study looks like now. Up here is our the study with the registry, and now we actually we can get samples, we can get discharge blood for antibodies, we can get the discharge, the discard respiratory swabs for sequencing. We download images for re-review, and then we have the immunobiology study where we get informed consent. We're working with both of these studies with the music study, and what we want, and we also were working with the CARA study, BloodNet for thrombosis and hemostasis. We really want to move into optimal treatment, comparing these consensus treatment plans. Unclear how feasible it's going to be to do a RCT. Most of these patients are treated on day one, like on presentation soon after with IVIG and or steroids. Eventually, how effective the vaccine is in preventing COVID, but will it also prevent MIS-C, or will there be vaccine-associated MIS-C-like complications is unclear because we don't know what's triggering it. So I just want to thank everyone who's worked with me on this, because it takes an army to do all of this work, and we have over 70 sites. We have actually over 200 site clinicians helping, including people from multiple networks. And we're funded both by the CDC. We work very closely with the CDC response team, and also with NHLBI, NICHD, and NIAID. So thank you very much. If there's any questions, I'd be happy to try to answer them.
Thank you very much. I'll lead off while we wait for others to chime in. First, thanks very much for this talk. Really interesting, and obviously we're all extremely concerned about this going forward. Any implications that you can think of around vaccinating children and any particular risks that it might pose for MIS-C?
Well, because we don't really know what's triggering MIS-C, is it something antibody-wise? The preliminary data that people have looked at doesn't necessarily show, differences in the antibody milieu, except for higher levels of certain IgGs, which you would anticipate because it's supposed to be a post-infectious. And the control groups that they looked at weren't kids who had asymptomatic, like what are their titers? So it's, we don't have the right control groups in these studies, and that's really important when you read these reports. What did they compare to? Did they have those patients who didn't have MIS-C, who you have a 30-day convalescent titer or 2 to 4 week convalescent titer of their blood? So most of them don't have that. And at the same time, if you can overall get rid of COVID and suppress the overall numbers in the community, of which children also help to transmit, you will overall decrease the overall MIS-C numbers, one would presume. So, getting the transmission of this down is really important. And children also get severe complications of COVID-19. Most of them are, for respiratory, have a lot of comorbid conditions, but for these neurologic complications and others, they don't necessarily have to have a lot of underlying conditions. So it is important that not all children are risk-free from acute severe COVID as well.
Great, thanks. Mark, I'm going to turn this over to you. I see a number of questions that have come up in the chat.
Okay, thank you, Ron. There's a question from Dr. Weinstein asking about polymorphisms that may be identified to suggest an increased risk for this complication.
Yes, that is very important. I'm just going to stop sharing my slides for a minute so I can look at the pictures here. So at our site, we've been doing very early on whole exome sequencing on all of these patients. I know you've been doing that, I believe, as well through your biobank. We have found quite a few, more than you would expect in a group of mostly previously LD children who didn't have pre-existing, conditions. Known prior multiple infections. We have found quite a few variants that we think are associated and we're working on that report. So I think that there is an interaction here with, in some of these patients, a genetic predisposition to having a hyperinflammatory response triggered by an infection or post-infectious.
Are you also in a position to see if children, say, who have Kawasaki disease have similar variations? In others, that there may be a more robust hyperinflammatory phenotype or genotype?
Yeah, that's a good question. So Jane Burns is one of the big Kawasaki researchers. I don't know if your site collaborates with her, but they have a big Kawasaki disease center in San Diego. They've been doing whole exomes for a long time and whole genomes, looking for genetic associations with Kawasaki disease. We have been participating at Boston Children's in that study. As far as I know, they haven't found the same number of patients. You know, the numbers that we found associated in our preliminary findings is higher than what you would expect to get that level of a hit rate. So I think that you know, people have been looking for genetic. There's some associations of genes with Kawasaki disease, but there's not as strong, and it's not associated clearly with primary immune deficiency genes.
Sure. Warren wanted you asked if you would mind commenting on the apparent lack of MISC in China or in Asia.
Yes, that is a very good question. And I've been on collaborative calls with people from China who wanted to set up a collaborative study on MISC, and we talked at length about, but you don't have any MISC. They have a ton of Kawasaki disease. Another big question is, Kawasaki disease has this huge predisposition for Asian patients. The numbers for Kawasaki disease are highest in Asians. MISC is not being seen in a lot of Asians, and even in these countries where they did have outbreaks of SARS-CoV2, we don't see these big reports of MISC. I will say, though, that the Chinese contained this virus very quickly. People stayed home, children stayed home, and the exposure, we can't rule out that the exposure was the same to the children in China as it was here. So it would be important, you know, to, before saying that they're completely risk-free, that the exposures would be similar.
Thank you. There's a question from Dr. Bornstein. From a community pediatrician standpoint, is there any value in performing pre-hospital lab work for a child suspected with possible MISC? And what would you recommend for now?
Yes, I think so, definitely. I mean, a CBC can be very informative, looking for neutrophilia and lymphopenia. If the patient really doesn't have much lymphopenia or neutrophilia, I personally feel a little bit more reassured about how severely ill they are. And that's one thing that because the ones who come into the hospital and are the sickest with shock tend to have very high ratios of neutrophils to lymphocytes, or procalcitonin very high, or the CRP very high. So somebody who has like a low CRP, pretty much a normal CBC, I would be much less concerned about the fact them having severe, being at risk. Doesn't mean that they can't progress, but you know, most of these patients have persistent fever, are very sick, and have really high markers of inflammation.
Thank you. There's a question from Dr. Singhal regarding relationship between prior known autoimmunity and MISC. Does a history of autoimmunity predispose to MISC, like Hashimoto's thyroiditis, for example?
Not that we saw in our study. One of the things that differs between our study and the case reporting is that you get from the States is that we have like a 50-page case report form that I know is very painful because you guys are participating in our study, our registry as well, and quite a few of the cases come from your center as well, and it takes a lot of time, but we get this big detailed history. it doesn't stand out having, you know, underlying. In fact, most of these kids are previously healthy.
I had a speculative question myself, Adrian, and that is, knowing that COVID-19 triggers MIS-C, do you have thoughts about a discrete infectious trigger responsible for Kawasaki disease that we just haven't identified yet?
So, you know, my area of research isn't Kawasaki disease, and it has certainly stimulated an enormous amount of interest from the Kawasaki disease community. Is this Kawasaki disease or is it something else? It does seem like the group of patients in our cohort that's younger, that doesn't have cardiovascular involvement, that has just all these features of Kawasaki disease, it does seem to me naively, you know, to look a bit similar to Kawasaki disease, a lot of those patients. So is SARS-CoV2 something that can trigger Kawasaki disease is a question. Is it a subphenotype? The Kawasaki disease phenotype is, I think that, you know, we have these giant, really broad criteria. Is the same thing going on in all of these patients? Unlikely. It's probable there's these phenotypes within this broad diagnostic group.
Thank you. Alessio Fasano had a question, but first had a comment thanking you for your talk and for coordinating this consortium. But specifically, he requested that you speak about the severe GI symptoms in MIS-C, and wondered if this had any relationship perhaps to microbiome issues.
So, you know, this is a question that is, it's a little bit confusing because remember, 50% of the patients with MIS-C are PCR positive. Although their CT values, which shows like active infection, can actually be really high, a lot of these patients. So probably they could be towards the tail of the end of their infection. As you know, you can carry the RNA around in the upper respiratory you know, area for a while, but we don't test the stool. COVID in acute COVID can really in children affect the GI system. And I can't tell too much of a difference between those who have acute COVID and MIS-C, and their GI systems very commonly affected with presenting symptoms. So how do we know COVID's not in the GI system? Because we're not testing the stool in these patients. How do we know it's not? You know, it could be viral involvement of how it perturbed the entire bowel, and it could be there for longer. And I have a lot of questions about that, but it's not so easy. It seems like it would be easy to get stool samples, but we've tried, and a lot of these patients just don't have much stool by the time they get, even though they presented with diarrhea and everything, by the time they get to the hospital, and it's unclear whether these rectal swabs are going to be super helpful. So if you have ways of studying that, I'd be very interested in talking further with you, because I think the bowel may be the key to some of this.
Thank you. There was, Alessio, did you want to comment?
Yeah, glad to. Absolutely, Adrianne. I believe that, you know, the presence of the viral in the GI tract, viable or not, for a long time that we've been seeing, and given the fact that MIS-C comes weeks after the onset of the infection, it may have some pathogenic role. So glad to discuss offline, you know, with you later on.
There was a question about asking if there's any knowledge about factors that determine the rate of recovery from MIS-C. We've had striking recoveries of children sick enough to require ECMO who were discharged from the hospital in a week.
Yes, that's a very good that's a very important observation, because the severity of illness doesn't seem to be as strongly associated with time to recovery of the heart. So that's something that we're looking at, you know, very closely and trying to do further studies. But just because somebody has really severe cardiac involvement and really poor function on echocardiogram, doesn't necessarily portend that they're going to have a longer recovery in this disease, just off the top of what we've been looking at. So that's really, really important to note when you're counseling patients. And people already clinically have noted that wow, they can get so sick and go on ECMO and then they recover very quickly as long as they don't have a complication.
Thank you. There's a question about the vaccine and possible risk of precipitating MIS-C.
Yes, I get that question a lot. And to me, it's really unclear because we don't know what precipitates MIS-C. I personally, feel that if we can get rid of COVID and get the numbers down to nothing, then we're going to have many fewer cases of MIS-C. It's really unclear that it's, and the great majority of children who are antibody positive don't get MIS-C. It's very rare. So until we know what triggers MIS-C with these immunobiology studies, which Dr. Yonker and people in MGH are also focused on, we really won't be able to answer that question.
I have a comment from Dr. Yonker and a question about what are the best and first tests to evaluate cardiac injury in MIS-C?
Yes, that's a very good question. So the BNP or NT-proBNP is a very helpful test as far as looking whether the cardiac muscle is involved. It's been, the problem is that the patients who don't have cardiac involvement very rarely get these tests, so we can't really say what is the sensitivity, specificity, et cetera. And the patients who have acute COVID, a lot of them don't get echocardiogram, so you can't really compare there. But in the ones with MIS-C, these BNP is a very helpful test, and troponin leak, which you shouldn't really see in children, is also a helpful test. So I would order a BNP and a troponin. And if you could only get one, probably the BNP would be very helpful.
Great, thanks very much. A question from Dr. Carroll from the PICU asked about the relationship of this work with your earlier influenza work and whether you have seen immune responses or clinical phenotypes similar to MIS-C in the influenza population.
Yes, so that's very interesting because I'm actually looking at pulling out these patients who come in with flu who mostly have cardiovascular involvement. Same thing with sort of a brief vasopressor needs. Very few of them actually, though, end up on ECMO or have this level of severity. Most of them look more like toxic shock with just, sitting up in bed, able to communicate, but needing vasopressors. Happens somewhat with more with influenza B that can have more myocardial effects. But I'm trying to pull those patients out of our biorepository to kind of do a comparison with what's going on with this population. It's also very rare in that population of patients.
Thank you. I have one last question I'll squeeze in from Dr. Lin, inquiring about any association of MIS-C with children with genetic syndromes that have structural heart disease or other structural anomalies.
Yeah, we do have some patients in our patient population with underlying cardiac disease who met criteria for MIS-C. We weren't able to really look at their cardiac function because some of them had impaired function at baseline, but they also recovered back to sort of their baseline. But when you look at the numbers, it doesn't seem like it's a risk factor. I mean, there's a certain number of patients who do have underlying disease. I wouldn't say that it's a risk factor for MIS-C that I can see personally from my data.
That's great. I think the hour has arrived, and I want to thank you very much, Adrianne, for sharing this talk and sharing your extensive experience. We missed having a Porter dinner, but that's the new COVID era for us. So I'd like to thank everyone, and if we have any further questions, we'll forward them to you as well. And thank everyone for participating this morning. Ron, can I turn it back to you?
Yeah, I just want to thank you as well. I thought it was a great talk, and I also think the questions were right on point. So thank you very much for educating us about this. Much more to come, I'm sure. So I wish everyone a good day, and I look forward to seeing everyone next week. Thank you. Bye-bye.
Thank you.